Hi guys, this is recent advance about Meniere'S disease. Prosper Meniere described Meniere's in 1861, Holpike in Keynes 1938 giving the concept of endolymphatic hydrops, and Portman described the endolymphatic sac surgery. It's having unknown etiology till now. Male female ratio 3 is to 2 in India and male female ratio in international is equal. Classically described episodic vertigo, fluctuating progressive hearing loss, tinnitus with low pitch and fullness. It may be because of genetic infection, vascular, dietary, allergy, autoimmune, or endocrine pathology. Mostly 90% cases are unilateral, which over the 20-year may progress to bilateral disease, and bilateral cases about 10%. Main pathogens may be lipopolysaccharide deposition, which is glycoprotein secreted into the endolymphatic sac, which form the hydrops which lead to dilatation of the sac and duct about 2 to 3 weeks. Next episode take about 2 to 3 weeks because it requires dilatation of the sac and duct. So this is defective absorption and production of endolymph according to Sucknex, which lead to Risner's membrane rupture and mixing of endolymph and perilymph. Second theory may be excessive production of endolymph, and the third may be because of ionic homeostasis. So these three theories describe the endolymphatic sac dilatation, and endolymph is just like intracellular fluid which having more potassium, and perilymph is just like CSF composition having more sodium ion. Incidence of Meniere's disease about 15 to 1 lakh, prevalence 13 1 lakh. It's common into 30 to 70 years of the age. So this is about pathogenesis of Meniere's disease. The Shia staging described in 1935 having 5 stages. Stage 1 to 3 having minimum hearing loss, stage 4 having flat cough, and stage 5 having profound hearing loss or high frequency hearing loss. Because it is progressive disease, each episode increase the hearing loss. So this is Shia staging of Meniere's disease. The nystagmus mostly in acute phase on same side, horizontal nystagmus. In chronic phase they are opposite side, and in recovery phase again nystagmus on the same side. 50% associated with migraine, and 5% of Meniere's disease cases may have migraine. It is primary or secondary type. Primary means idiopathic, secondary may be because of migraine, trauma, syphilis, autoimmune, or other pathology may involve the sac. What is Lermois syndrome? Lermois syndrome is opposite of like Meniere's disease, hearing loss followed by vertigo. Henneberg sign because of fibrosis between the vestibular macula and stapes plate leading to vertigo because of pressure changes. If loud sound induced vertigo, it is called Tullio phenomena. Every patient should get an MRI contrast to rule out the other CP angle pathology. Recently, Veronese Society in 2015 described two types of vertigo, two types of Meniere's disease, definitive and probable. But in definitive vertigo, having 20 minutes to 12 hours, audiometry documented oral symptom plus no other alternative diagnosis. In probable, there is time period is increased 20 minutes to 24 hours and oral symptoms are same, but there is no PTA diagnosis. DD may be vestibular migraine, vestibular schwannoma, autosyphilis, autoimmune disease, and other metabolic syndrome. Diagnosis of Meniere's disease mainly clinical, characterized by vertigo, SN loss, and tinnitus. Mainly low grade hearing loss in low to mid frequency hearing loss in PTA. CC test showing recruitment, electrocochleography showing SP and AP ratio more than 0.8, or MRI should be done to rule out other alternative pathology or diagnose the endolymphatic hydrops. So total hearing loss in Meniere's disease is very rare. If there is total hearing loss is present, you should think about alternative diagnosis. It is not a Meniere's disease. Means dead ear is not present in the Meniere's disease. So what is the treatment? Treatment is, this is the paradigm of the treatment. what I'm telling you, the recent advance is salt and stress restriction not having any evidence of helpful in the mania disease. Managed device is not helpful. Vasodilators completely useless. Beta-statin useless. Diuretics useless. Tenotomy of stapes tendon or tensor tympani is not going to help. What is helpful is intratympanic gentamicin or Dexona at the interval 0, 1 month and 3 months. If it is more than 50 dB hearing loss, you should give gentamicin. If it is less than 50 dB hearing loss, you should give Dexona. And if efficacy of gentamicin 91%, Dexona is 71%, endolymphatic sac surgery is not going to be helpful. Vestibuloablative surgery like labyrinthectomy is effective in 95% of the cases. Vestibular rehabilitation therapy should be given to other associated disease like BPPV and bilateral autoimmune disease. And vestibular neurectomy is effective in 96% cases. It's very effective if refractory Meniere's disease. It is Dexona and gentamicin injection is quite helpful. Most of the cases can resolve by gentamicin and Dexona only. Over result is 90 plus. Endolymphatic sac surgery is not recommended. It's big no to this. And this is the total labyrinthectomy. It is very effective. And this is vestibular neurectomy. It is also effective. The most effective therapy is vestibular neurectomy in refractory cases. Thank you so much.